Hello everybody, today I am going to talk to you about a case of unilateral otosclerosis in the left ear in a young adult where I did left side endoscopic stapedotomy. This is the PTA report showing 53 decibel conductive hearing loss in the left ear with Carhart's notch at 2K, and the impedance shows A type in both the sides. So next is the CT scan report. I did a HRCT temporal bone, and you can see that these are the axial cuts. So I do not see any evidence of otosclerosis in these cuts, nor was it reported, but basically there was no other pathology. It was absolutely a normal HRCT temporal bone, well pneumatized mastoids, all the ossicles well formed. There is no congenital anomaly, and middle ear is also well formed. But clinically they have not reported any evidence of otosclerosis. So starting the surgery using a 0-degree nasal endoscope, which is 4 mm diameter, placed in the left side ear canal after a thorough irrigation and removing of debris, and using the flag knife I am making the radial incision at 12 o'clock position. This is the left ear, and then again at the 6 o'clock position, starting from the annulus and coming about 6 mm laterally, and then using a horizontal incision to join both the radial incisions up to bone depth. This is to raise the posterior tympanomeatal flap. So one must raise this flap in an atraumatic fashion. There should not be any tear in the flap. So gently I am raising the flap using the circular knife. And for hemostasis I am using adrenaline soaked cottonoids in between underneath the flap for decongestion. So this is a cottonoid placed underneath the flap because the flap tends to bleed once we are raising it, especially in the inferior part. And now I have almost reached the fibrous annulus. Using the periosteum elevator I am gently elevating the flap in the middle and to expose the middle ear, and what you can see is the TS joint coming into view. So one must elevate the flap very gently without causing a tear here, otherwise it will lead to residual perforation and might affect our hearing result. The chorda tympani is seen inferiorly. It is a little inferiorly placed as you can see, and with the flap it is coming up. And next you can see the IS joint very well and the stapedial tendon. Also the horizontal part of the facial nerve has come into view. And now I am palpating the malleus handle to see the mobility. Incus is mobile but stapes appears to be fixed. So the malleus handle is not in view, but I can palpate it with the curved pick. And when I am doing that I am seeing the movement of the incus. Now I am curating the posterior superior bony wall from the notch of Rivinus and coming down posteriorly so as to see the pyramid of the stapedial tendon. So that is the lower limit of the curettage. So one must be able to see the pyramid of the stapedial tendon very well, and the IS joint and the foot plate and the horizontal part of the facial nerve. So these are the things, structures which should be well visible, and that will limit the that will determine the extent of the curettage. So after that I am able to see the foot plate very well, stapedial tendon, the pyramidal process, stapes, suprastructure and the incus. Next I do stapedial tenotomy using the chlorotomy scissors. I have done that now, and once I do that I am able to see the stapes suprastructure very well. Next I am doing the IS joint dislocation with a curved pick. Very gently one must do this step to prevent any accidental mobilization of the foot plate. So now I am down fracturing the stapes crura, very thin crura, so it is coming out very easily. Otherwise sometimes we need chlorotomy scissors to remove it, but in this case simple ground fracturing with the curved pick I was able to do a complete removal of the suprastructure. And now I am going to take out the stapes suprastructure, the head with the head, neck and the two crura. Once I have done that, now I visualize the foot plate. After doing suctioning, it appears to be a thin biscuit focus, bluish foot plate seen very well. I use a gel foam to absorb the whatever blood that has collected there over the foot plate. I do suctioning over that. This is a chorda which you can see, very inferiorly placed chorda, and we can also see the promontory and the round window. So now I will use a straight pick, 0.5 mm diameter and 0.6. I have got two. So I first take the 0.5 mm diameter straight pick, the perforator, and I will perforate the foot plate in the posterior aspect. One must do it posteriorly because the utricle lies little away from the foot plate here. Anteriorly the saccule is very close to the foot plate, so one must avoid making an anterior fenestrum which will injure the vestibule. So with gentle rotatory movements, I am trying to make a fenestrum of 0.5 mm diameter in the posterior part of the foot plate. Once I have done that and I have felt a give, the patient also complains of mild vertigo, and you can see that I have made a fenestrum here. Next I take the 0.6 mm diameter pick and try to widen the fenestrum in the foot plate. Very gently one must do that to prevent any subluxation of the foot plate or mobilization of the foot plate or fracture. Luckily this is a thin biscuit focus, so I could make the fenestrum very easily. I am just widening it. You can see the perilymph coming out. So next, using the burr, I am widening the foot plate, the fenestrum, again very gently. So this is good enough. Now I am taking the measuring rod and trying to assess the length of the piston that I will require. One must take 0.25 mm extra so that that part lies medial to the foot plate. And next, after having selected the Teflon piston, which is about 0.5 mm diameter and 4.5 mm long Teflon piston, I have opened the mouth of the piston and gently with the crocodile forceps I am introducing it, and with the help of the curve pick I am guiding it down into the fenestrum. As you can see, the medial end goes into the fenestrum, and then the upper part, the distal part, is hooked around the incus long process. Very easily it goes in. At the same time, I am able to visualize the medial end of the Teflon piston also. It is fitting very well into the fenestrum. Now I crimp the Teflon piston using the alligator forceps, and again I ensure that the medial end is lying well within the fenestrum in the foot plate, and it is loose there. No, it should not be snugly fitting, it should be able to move well. And then I deposit the flap. Before that, I put a gel foam to suck the excess blood, and I am doing a bend test and a lift test to see whether the piston is slipping out of the fenestrum or not. It seems to be securely placed. Then I place a gel foam in the medial part so that it doesn't migrate and keeps the Teflon piston in place. Next I deposit the posterior tympanomeatal flap
56, 45,
and I do
56,
a sound test.
45,
45,
62,
62,
38,
38, 44, 39, 29, 10, 16, 32, పెంచుగలవాడు వెంకటమ్మ సూర్యం.
okay.
So after having ensured that the patient is able to hear well, even responding to whispering, I reposit the flap and I place gel foam to keep it in place. So I have got satisfactory results. Presently the patient is able to hear well. So I just clean out the excess blood and I place gel foam and pack the ear. Thank you for watching.